Everyone. So my next video is on the topic vasodilators, inodilators, and inotropic agents in treatment of congestive heart failure. Now I'm going to discuss with you vasodilators, inodilators, and inotropic agents in the treatment of congestive heart failure. And before I start my video, I want to request you, if you like this video and if it is useful to you, kindly subscribe to my YouTube channel. That is Dr. Nitika Pharmacology Discussion. And now I'm going to start with my topic. Now, first of all, vasodilators. These are the venodilators or the arteriolar dilators. Venodilators, they decrease the venous tone, decrease the they cause the vasodilatation. So they decrease the venous return, increase the capacitance. Venous capacitance is increased and they cause the vasodilatation, they cause the peripheral cooling of the blood, they decrease the venous return, and they decrease the preload. Plus, they improve the venous capacitance. Dilatation of venous blood vessel leads to decrease in the cardiac preload, increasing the venous capacitance. And arterial dilators, these reduce the systemic arteriolar resistance. They will cause the systemic arteriolar resistance is reduced, so they will reduce the afterload. Now, nitrates, these are the venous dilators, and these are used for patients with the congestive heart failure. And if a patient is intolerant to ACE inhibitors, the combination of hydrolazine, which is the arterial dilator, and isosorbide dinitrate, which is the venous dilator, is commonly used. Amlodipine and felodipine. These are the dihydropyrimidines. They have a less negative inotropic effect. Means they will decrease the heart rate to a lesser extent. They decrease the cardiac output to a lesser extent. And they seem to decrease the sympathetic nervous activity. Arteriolar dilators, they decrease the peripheral vascular resistance. Afterload is equal to systolic ejection fraction into peripheral vascular resistance. As they decrease the arteriolar resistance, peripheral vascular resistance is reduced, so afterload will be reduced. Now, the most commonly used vasodilators, venodilators are glycerol dinitrate, isosorbide dinitrate. Arteriolar dilators are hydrolazine, minoxidil, calcium channel blockers, and potassium channel openers like nicorandin. Mixed dilators are ACE inhibitors, angiotensin 1 receptor blockers, pentolamine, prazosin, which are the alpha blockers, nitrosuperoside, ambrinon, and milrinone, which are the phosphodiesterase inhibitors. These are the inodilators. Now, what are the inodilators? These are the mixed vasodilators, plus they also increase the force of contraction. These are ambrinon and milrinone, and they are selective phosphodiesterase 3 inhibitors, short-term support in advanced heart failure. Now they increase the levels of 5' cyclic AMP in the body, because the cyclic AMP doesn't get converted into the 5' AMP, and the cyclic AMP levels are increased. And when the beta 1 receptors are stimulated, cyclic AMP levels get increased. So they will lead to increased stimulation of protein kinase. Increased stimulation of protein kinase will lead to phosphorylation of the protein kinase, and then there will be increased contractility of the heart will be there. There will be increased myocardial contractility because of the phosphorylation of the protein kinase. The troponin C binding will be increased, and actin and myosin will combine together, and they will be increased contractility. And these are also the vasodilator. Cyclic AMP is also the vasodilator. So it will lead to increase vasodilatation, so leading to decrease in the preload because of the reduced venous tone, venous resistance is reduced, and if venous capacitance is increased. So the sodium nitroprusside, it is used in the congestive acute heart failure. It causes the venodilatation, so it decreases the preload. Headache is most commonly seen with the sodium nitroprusside or glycerol dinitrate. Hydrolazine and nitrates, these are both the arteriolar dilator, and the nitrates are also the direct inotropic effect they have. Heart failure with renal damage, these are used in heart failure with renal damage, given as an adjuvant who are already taking diuretics, digoxin or ACE inhibitors. Now, this is cardiac remodeling. What is cardiac remodeling? When there's increased levels of the angiotensin 2 in the body, increased release of aldosterone is there, increased sympathetic activation that will lead to cardiac remodeling. That is the connective tissue and abnormal myocardial cells proliferation, and that will lead to decompensation phase. Increased ischemia, ventricular wall tension will increase, and residual volume will increase. Decrease mechanical performance, altered ventricular geometry, death of myocytes, and increased workload on the remaining myocytes. This is what is the cardiac remodeling. Now, vasodilators, these are the arteriolar as well as the venodilators. ACE inhibitors and angiotensin receptor blockers, these are vasodilators. ACE inhibitors act by inhibiting the action of the angiotensin 1 into the angiotensin 2 conversion. So angiotensin 1 will be more, but angiotensin 2 will not be produced. So there will be no vasoconstriction, and also they decrease the aldosterone release from in the body. So there will be decreased sodium and water retention. And these are helpful in the cardiac remodeling and used for all grades of heart failure. Angiotensin receptor blockers, these block the AT1 receptor. So the action of the angiotensin 2 will not come. Compensatory activation of the AT2 receptor will be there, and they have a better side effect profile. So the angioedema and the cough is not there with this angiotensin receptor blockers, and angiotensin 1 remains blocked. So angiotensin will increase in the body. Means AT1 remains blocked, but angiotensin levels will increase in the body. This is how the action is there. Angiotensinogen gets converted to angiotensin 1 by renin, and angiotensin 1 is produced, it's converted to angiotensin 2 by angiotensin converting enzyme. So angiotensin converting enzyme is inhibited, so there will be decreased release of aldosterone, decreased sodium reabsorption, decreased ADH release. So this will all lead to increase in the sodium and potassium from the body, and that will lead to decreased blood pressure. And this bradykinin, it gets converted to inactive peptide by the angiotensin converting enzyme. And when we give the angiotensin converting enzyme inhibitors, bradykinin levels will increase in the body. So it will lead to increased prostaglandin synthesis, leading to vasodilatation, leading to decreased peripheral vascular resistance, leading to decreased blood pressure. So this is the action of the beta-adrenergic agonistic drugs on the heart muscle. Is the dopamine, dobutamine, these are the drugs which act by the stimulation of the beta-1 receptors, and there is increased production of cyclic AMP. And this activates the protein kinase, which in turn phosphorylates the calcium channel. And then phosphorylation of calcium channel increases the calcium flow into the cell, causing increased force of contraction of the heart muscle. And phosphodiesterase inhibitors, they also inhibit the hydrolysis of the cyclic AMP into 5' AMP. So cyclic AMP action will be increased. So protein kinase will be more produced, phosphorylation will take place, and that will lead to increase calcium channel phosphorylation, leading to increase inflow of the calcium from outside of the cell into inside, and there is increased force of contraction. Now, dopamine and dobutamine, these are used in acute heart failure and increase the force of contraction without increasing the heart rate. Dobutamine may not be given along with beta blockers. Dopamine at high concentration causes vasoconstriction because at low concentration it stimulates T1 receptors. At medium concentration and beta-1 receptors are stimulated, and at high concentration alpha-1 receptors are stimulated. This is how the action of dopamine comes. D1 receptors are stimulated in the kidney, so that increases the GFR, natriuresis is produced, increased renal blood flow is there, increased And beta 1 stimulation at 5 to 10 microgram per kg per minute. That is the beta 1 receptors will be stimulated, so heart rate will be increased. And alpha 1 stimulation in the and that can lead to vasoconstriction at the dose greater than 10 microgram per kg per minute. So failure with low cardiac output with compromised renal function, this is used dopamine with failure with low cardiac output with compromised renal function. Dobutamine, this is the beta 1 selective agonist, so it will increase the heart rate, increase cardiac output, stroke volume, urinary output will increase. And monitor, we have to caution is monitor heart rate and blood pressure. So that's all with the vasodilators, inodilators, and inotropic agents. I hope you understood this video. And if you understood this video, kindly subscribe to my YouTube channel. Let's Dr. Nitika Pharmacology Discussion. Thank you. Be happy, be healthy, be blessed. Thank you. Happy learning.